Okay, we're going to call to order the low. Hello? Okay, we are going to call to order the Low Barrier Homeless Shelter Task Force. This is the meeting of August 29th, and we are present here at the Indiana Government Center, South Conference Room 12 in Cardinal Hall. So we will call this to order, and then we'll move into the roll call of our task force members. I would ask that the members present their names and then also identify if they are either in person or on remotely. So I will start off and we'll move to my left. Tom McGowan, in person.
Jeff Bennett, in person.
Jack Sandlin, in person.
Tim Brown, in person.
Bradley Padula, in person.
Chris Blessinger, in person.
Jacob Seid, in person.
Now, if we could do a roll call of those that are virtual, please. Please state your name, location.
Cindy Ledbetter, via Microsoft Teams meeting.
Thank you.
Chelsea Herring-Cozy from CHIP via Microsoft Teams meeting.
I'm Corey Carey with FSSA's Division of Mental Health and Addiction via remote Teams meeting.
Rick Alvis, Wheeler, virtual.
If we'll come back to the in-room, if you just state your name and location, please.
Justin Moed, State Representative, Indianapolis.
In person.
In person.
Thank you.
Karen Holly, Marion County Public Health Department, in person.
Great. I believe that concludes our roll call. So thank you for everyone in person and also joining us remotely. At this time, I would like to have a discussion about the approval of the minutes. Any questions? Not hearing any, I would call for a motion, please.
I move to approve the minutes.
Thank you.
Second.
Motion's been seconded. All in favor? Do I have to do roll call? All right, I was gonna try to avoid it. All right. We will do roll call. I know we do that at other state meetings. Tom McGowan, in person, aye.
Jeff Bennett, in person, aye.
Jack Sandlin, in person, aye.
Karen Holly, in person, aye.
Justin Moed, in person, aye.
Tim Brown, in person, aye.
Bradley Padula, in person, aye.
Chris Blessinger, in person, aye.
Jacob Seid, in person, aye.
If we could get the roll call virtual, please.
Cindy Ledbetter, virtual, aye.
Chelsea Herring-Cozy, virtual, aye.
Corey Carey, virtual, aye.
Rick Alvis, here, aye, whatever.
Thank you, Rick.
I's here.
Does that conclude the virtual roll call? So, thank you. So, motion carries on the approval of the minutes. The next item on our agenda today is the introduction of Lauren Rodriguez. And I'm gonna ask my friend Jeff Bennett to do a quick introduction before Lauren speaks.
Yeah, and this is, we talked about this a little bit at the end of last meeting. So I'd like to introduce Lauren Rodriguez, who's the director of the City of Indianapolis's Office of Public Health and Safety. One of the things that we've talked about among many is as we conduct our work over the remainder of this year and issue a report to the governor and to the General Assembly, we want to make sure that whatever we do, whatever we propose, doesn't simply duplicate existing efforts that are already happening, whether it's in the city of Indianapolis or other cities across the state. And so we've, in our title, we are the Low Barrier Homeless Shelter Task Force. But that's not to say that there aren't already low barrier options and services that exist in the city of Indianapolis specifically. One of those resources is called the Assessment and Intervention Center. And in a previous iteration, it was called the Rubin Engagement Center, and it has evolved as our work has evolved in the city related to community justice, and the location, physical location has moved from Market Street downtown to the Community Justice Campus out at Twin Air. And so I asked Lauren if she would spend a little bit of time with us today to sort of talk us through what the AIC is, how many beds it has, what its take-up rate is, capacity, who it's serving, and how people come to be at the AIC, and then where they go upon discharge from the AIC. And if there's any other pertinent information, Lauren will share it. But as we move into the fall and begin thinking about what we might recommend, we want to, I think, be mindful of existing resources across the city. So Lauren, if I can turn it over to you for a bit.
Yeah,
Thanks for being here.
Thank you. So OBHS oversees the budget for the Assessment and Intervention Center, the AIC, and we work with Eskenazi Health. They staff it, so we provide the dollars to staff it. And we have a total of 60 beds. However, only 30 of them are being utilized as of this month. So what we have found at the AIC is it's low barrier, but it's not low barrier in the sense of what this task force is trying to accomplish, I believe. And I know, Chelsea, I heard you're on here too. I don't see your face. I apologize, but you know, I've heard her say that it's not just really low barrier for our community members in the sense that you can't smoke in there, you can't bring your cell phones in there. Although we allow for lower level offenses that people have pending cases, electronic monitoring, we allow for that to come into the AIC. There's just some restrictions because it's city-owned property. We run into the issues of, especially the smoking issue. That's a lot that's going on, but we're working really closely with our community members and organizations to try to navigate those barriers. AIC accepts individuals who have a mental health and or substance use issue. Rubin had something similar in the sense that it allowed for substance use disorders, but as well as those who are experiencing homelessness or those who are unsheltered. AIC doesn't really do the unsheltered homelessness piece. So individuals who do come into the AIC though, they do fit into that category. So I brought in some quick stats from July of 2022. At the time of referral, 82.4% of our total 199 referrals were homeless and or had housing insecurity status. That's been self-reported. So we do accept those who are experiencing homelessness and housing. However, if you knew who Rubin was prior, anybody would be able to come even if they didn't have a substance use disorder and were homeless. So it's a little bit of a different key for AIC. So what happens is they come in, it's all voluntary. You come in, you get assessed, and then you can move up to the second floor, which is what we've labeled as the Rubin Engagement Center floor 2. And those individuals will stay with us. And
This is background.
okay. So we have the admissions to the second floor for July of 2022. Out of 199, we had 131 individuals who stayed on the second floor. And the average length of stay there would be 2.7 days. And it ranges from 1 to 20 days. So individuals can stay there for a longer period of time if they're being connected to resources. So they get assessed, they move up to the second floor if they need it, and then they're connected to the resources that they may need. One of the barriers that I've noted with the AIC, and I also sit on Eskenazi Health Center board here in Indianapolis, is the barrier to medication. So those individuals who are coming into the AIC who may need medicines, most of the times they haven't been connected to a prescriber or in a while, right? So they need to go back in, and AIC doesn't have the ability to administer meds in the way that they can prescribe. So we do have connections with Pedigo, who can provide a shorter amount of medicine if they have mental health services or have been prescribed medicines before until hopefully they can get to a prescriber. However, it's the length between leaving the AIC or coming to the AIC to being connected to a prescriber is 3 to 8 weeks, which is causing issues because people then will come back because they're not on their meds, right? And
Yeah.
so we have that issue that has been highlighted for me, actually most recently as today. I had somebody that was out in the community and they were going to the AIC on Friday, they got connected, they got an appointment, and then their appointment is not until 3 weeks with the prescriber. So one of the issues highlighted by the AIC is that one of the barriers is remote calls. So we are allowed to call in for appointments with your prescriber. However, if you don't have access to a video call, then you cannot get to see a prescriber until you can go in person. So that's caused a lot of
And
issues.
is the 3 week, is that the backlog at the Pedigo Clinic or?
Yeah, for all Eskenazi FQHCs, I think all FQHCs in Indianapolis, because we have a network with all of them. And any prescriber. So most people who come into the AIC don't have health insurance, and so we also connect them with health insurance as well. And we have discharges range because it's a voluntary space. And so people will leave for whatever reason. However, that doesn't stop them from coming back. We allow them to come back. They just have to go through the whole process, taking your clothes off, going through the bed bug burner, getting assessed, taking a shower, getting new clothes. But that's another barrier is they can't just come and go freely. I will say right now we're looking at different consulting agencies to see how we can expand to the 60 beds in the most effective way possible. One of the issues that we are seeing is hiring the staff at the AIC. So we have 60 beds, and I do believe we have the ability to expand to 60 beds. We just don't have the staff to do it. I believe one of the positions has been open for over 1 year and 3 months at this point, which is critical for us to expand. We also have shelf space at the AIC that we're going to use the consulting agency to see, do we need additional beds? Do we need a place for those who are being immediately detained? And we can help them there. But that's what I have right now. And I have more stats if you guys want them. I have it by data, by race and by data. The housing trends have gone up over the summer months. We're about 82%. In July and January, we're about 65%. And most people get discharged to outpatient recovery programs. I know, Jeff, you wanted me to highlight that for you all. But this is all data that's being collected by asking. So we're working on a data system. The data system that we originally had wasn't navigable for our individuals that are working at the AIC. But most of them are going to outpatient recovery centers.
So on the front end, how are people being referred to, how are they accessing the AIC to begin with? I know there was a discussion with IMPD over sort of screening tool. Like, is that working or not working, or how otherwise are people getting to?
I have heard that's not working.
It's not working. You're right.
I was leaving.
That's what.
I was leaving this.
I'm glad you led the with.
So AIC is open to anybody to utilize it, including those outside of Marion County. We do have people outside of Marion County that utilize AIC. We can do walk-ins. Most of our stuff comes from the emergency departments. Probably people who have been immediately detained first. So IMPD will immediately detain them, which is up to 24 hours. And then they can be released. We also have implemented, because of the IMPD screening tool that wasn't working, it's just clunky. They would have to take their computers out of their cars, then go through the whole thing. It was just a lot. So we had asked them just to drop them off and we'll do our own assessment there at the AIC. And
Would that still be voluntary or involuntary
so
at
you
that point?
have to ask. You have to ask. So IMPD officers will say, can I take you to the AIC?
Okay, so it's still voluntary.
Yes, still voluntary. Everything's voluntary. But we've realized that IMPD cars can be triggering to people. So we have implemented a Lyft ride program that anybody now in Marion County can utilize. You call the AIC, somebody wants to go to the AIC, they don't want to ride with you, they don't want to ride with an officer, they don't have transportation, and the AIC will set up a Lyft ride for them to come there. And that would be the only stop. So we were piloting that on North District for IMPD. It wasn't really being utilized for whatever reason. And so we've now opened it to everybody, all districts and all organizations. And we're able to get them to the AIC at least, and then from there we can assess.
And does a person have to be justice involved to go to the AIC, or can anyone go?
Anyone. We have had people come to actually OPHS's office, through it, like either the, MAC or through DMD. They'll come and ask questions and maybe have some mental health and or substance use issues that are pretty apparent. And so we'll talk to them and then we'll eventually just take them over to the AIC. MCAT officers have been really great with that. I don't know if any of you met MCAT officers. They're amazing people, and they're able to transport them over to the AIC.
What's been the utilization rate of the Lyft rides since you've opened it up to the different districts?
So we just opened it up, and this is, as we opened it as of 7/17, we've had 3 rides so far.
And when somebody's discharged to an outpatient program, are they discharged with a housing option or without a housing option?
So we don't do housing options right now, and that's one of the things that we've been highlighting. That would require more people coming to the AIC, but that's something that we're looking at including. Outpatient services, we can only track them to the outpatient provider, but the outpatient provider doesn't give us any additional feedback for what happens there.
And Jack, I think that's a great point of one of the topics that we're gonna talk about is the whole wraparound service, you know, where you have a hub where everything's located in one spot. Because obviously it's a little bit tougher at that location, but if we can establish that hub, then we'll be in a position to one-stop shopping on everything. One more question. Why does Eskenazi not provide the medical services at your location to avoid these 3 to 8 week? To me, that doesn't make sense, but I'm sure there's more to the story. For example, Horizon that Jeff and I went to has a clinic, and under our concept of the hub, healthcare would be a critical component of this hub. That once you have them, that you have to get them health. Like the guy that literally on the corner of Washington and Meridian that I walked by that was pretending to throw things at car, clearly schizophrenic. So once you get them in, I think this hub concept is that we gotta care for them on the spot. So just curious why that is not happening at your location.
So AIC is not a health center in the terms of billing and practicing. So we don't employ physicians that go there. So we do have nurses that will go, but they can't prescribe. That you would need a physician to be there. And we have our connections with all of the FQHCs and the other prescribers here in Indianapolis. I've been told there's a shortage on prescribers. Specifically, I was talking to Dr. Hout today. I don't know if you guys are all familiar with her. She is the CEO over the Eskenazi FQHCs, and she was telling me that the biggest thing was the prescribers cannot take remote calls about the videos. That's what she just kept saying. So if they can take remote calls without a video, we can get more people into appointments for their medications.
So one question that Chelsea was texting me is actually related to maybe the AIC operation and not how it relates to necessarily the work that we're talking about. But is there an option for the AIC to use the homeless management information system, HMIS?
So there is an option, and I believe I know I've talked to Chelsea about this, and Chelsea, she's.
You can see her, but you can't see her.
It's so weird. I've seen these elephants and it follows you around. But we can utilize it right now because we put a freeze on our own database system. We are not implementing anything additional. And I think we have 3 providers that can help build out the system for us to start collecting the data and then integrating outside data. I don't know why Eskenazi has not chosen to use HMIS right now. I think primarily it's because we don't deal with the housing piece as much.
But I think and this would be something that we could bring up with Eskenazi separately. I think even though housing isn't a service being provided at the AIC, the ability to follow that person across the system would be, you would have real-time visibility of all of the resources. So HMIS, for folks online and around the table, is a shared information management system database that all of our providers, almost all of our providers use to enter client data and track referrals across the system. And even those that don't use it may have a sort of backdoor bridge between their database and HMIS. So we have that visibility across the system. So I think for future discussion, maybe with Eskenazi, I think HMIS would be vital. Then, you won't necessarily lose where that person goes after they discharge or leave.
Yeah, and I'll just add really quickly, I'm sorry you can't see my face. I'm on camera, but I don't know if it doesn't move around or I think it becomes really important, and I know Eskenazi, other parts of Eskenazi, they are an agency user and they have HMIS agreements with us for their other programming. But what becomes really critical is if you're seeing folks that, are coming into the AIC, it helps to be able to document disabling conditions. So people that might be using, substances or having mental health issues. It helps document chronicity. If we see people that are coming in and out that are experiencing homelessness, like over multiple years or episodic, multiple episodes, and those folks tend to then be prioritized for housing. But if we aren't able to capture that or document that, it makes it a little more challenging when we're trying to match services and resources by vulnerability. And it sounds like AIC might see some highly vulnerable folks that may have, again, multiple kind of challenges with mental health, substance use, justice involvement, all of those kinds of things that tend to then be prioritized for housing because these are the exact folks that are utilizing lots of systems. And again, the best practice is you try to look at those high utilizers of multiple systems and really focus on permanent housing, which then reduces reliance on justice systems, emergency systems, things like that. It sounds like those are some of the same folks y'all are seeing at the AIC. So would just love to think through how we could integrate a little bit more.
Chelsea, I appreciate that. You are actually on the list for people to talk to with the consulting agency and how to better utilize the AIC. So somebody's gonna reach out to you.
That's great.
Thank you. A couple of questions real quick. You mentioned 30 beds are utilized out of the 60, correct? Is there a specific reason? Is it the lack of staffing that's preventing the other 30 from being staffed, from being served?
So it actually started with COVID. We could only open up to 30 beds at first. And then once we realized that, okay, COVID's being a little less restrictive, then it was posting positions. So it's one of those chicken and egg things. Do we open it up to 60 beds and then expect our staff to work overtime and they're already working overtime? Or do we wait until those positions are filled and then open it up to 60 beds? So it's we're weighing it. And that's why we want to do this consulting to see how we can effectively utilize it. Maybe it's that we don't open it up to 60 beds to where we utilize the 30 beds twice. Maybe it's we use the other 30 beds for emergency shelters, or the mental health courts need some beds before an individual is placed in housing. That's what this consulting will help us.
And then the two quick questions. The second one, are there any emerging themes or evolved themes about the demographics of the constituents who are using the Rubin Center or the AIC, such as homeless veterans, or are there any consistent repeat users
Good
of the
question.
facility?
Yeah, so one of my biggest gripes of the AIC is that we see primarily white men. That is, it's more than half is, they're white men. And we know that it's not just white men that are experiencing substance use and or mental health issues in Indianapolis. And so what we've been trying to figure out is how do we recruit more people to come? So I will say that Jennifer Chinelli at the AIC is doing really great outreach to churches, it's just smaller community organizations. Right now we're working with Eskenazi to build out the mental health toolkit that will allow organizations to be trained in seeing like, okay, this individual keeps coming here with this issue. They actually may have an underlying mental illness or mental health conditions that's not being treated. Or maybe they need connected to substance use resources and they're gonna be trained to say, okay, I recognize this in you. Now I'm gonna connect you to the right person. That way it's not a continuous
And
cycle.
then the final question, what are the top 2 to 3 reasons of why you keep seeing the same or these individuals? So maybe to rephrase the question, what percentage of the 30, if you look at the last year or 2 years or 3 years, have been patients that are dealing either with the criminal justice system versus non-criminal justice system patients? And what are the issues that are dealing with? I mean, you mentioned mental health and substance abuse. I just want to confirm the percentage.
So just to let you know, we didn't open the AIC until the end of 2020 in December. So it hasn't been open that long. And so most of our referrals come from the EDs, but we also get referrals from the criminal justice department, but we don't ask people if they have pending cases. I mean, it's a part of the form, but we don't require them to disclose that. Unless it's like a violent felony. We can't have violent felonies, but we have about discharges. We have a little bit over 5% that are criminal justice involved that have been reported as criminal justice involved. To go back to your veteran status, we have 4% of July statistics that were reported veterans, and they have to self-report that too.
Thank you.
Your stat on white males being served at a higher rate, that reflects almost exactly the percentage of white males who are experiencing unsheltered homelessness, the PID count, which is different from homelessness overall, which is disproportionately affecting Black residents. So it's interesting that the AIC is tracking to unsheltered versus homelessness overall. And remind me when the consultants work will finish.
Well, we haven't hired them yet.
Okay,
So
so
we're
when
right
will it
now,
start.
hopefully this year. We have to,
It may not be in time for us.
Not for us.
Yeah.
probably not, but we can keep you guys updated.
Yeah.
If there aren't any other questions, go ahead, one more.
One question, with the Pedigo and prescription drugs, but are there ways that you guys can contract with other providers so there won't be such a lag?
So it's a referral base, so it's not even contracts, we just call around and see who's open for appointments. So our staff calls everywhere for these appointments. And yeah, the biggest thing that everybody keeps telling me is remote calls without videos. And only FSSA can help with that.
Interesting. Well, Lauren, thank you very much. That was very important. We've tried to spend some time educating everyone on our team, so that was very helpful. We're gonna move on now to the next agenda item, and that relates to this. The next agenda item relates to the wraparound services, which connected very closely with what Lauren talked about, that we need a hub. You know, we need the mecca of the location where you can solve all problems. As daunting as that may be, it's got to be that location that's addressing health, interim, permanent, all these things, even though permanent could be elsewhere. So we're going to talk about that. One thing I wanted to thank Rick Alvarez, who had his team take me on a tour of Wheeler Mission's men's facility on Market Street, which was extremely helpful. But the big one we wanted to talk about today is Jeff and I, spent some very valuable time with the leadership team at Horizon House. And I think we got some good work done there to talk about what we need to do. And it all relates to an end report and recommendation ultimately of how we try to solve this in one location, get the proper funding. So what we're gonna talk a little bit later in the agenda is we've got to start making specific progress in terms of the layout of the recommendation, what the funding priorities are, and then how we ultimately work on this facility. So Jeff, do you want to talk a little bit about our discussion with them and where we seem to be seeing eye to eye on what the mission could be for this group?
Yeah, there are, so, and again, in the interest of not duplicating what's already happening in the local system or in other cities or counties across the state, I thought it was important for us to spend some time with Horizon House. And I've met with Horizon House, I think, 3 times since we last met as a group. And I wanted Tom to have a chance to come over to the campus. So Horizon House is a nonprofit day shelter in Indianapolis. It's located on the near east side of downtown. And they are open Monday through Friday, but currently limited hours. Horizon House has been around for many years. They have recently launched a new strategic plan. The plan is done. They're in the rollout and implementation phase. And a substantial amount of what they want to do, I think we would consider to be the services provided by a housing hub that we might build. And so why build something that already exists that you could support? But they have some needs. So as I mentioned, they are open limited hours right now. And we think, based on our conversations in this group and outside of this group, that a housing hub or navigation center probably needs to be open 6 days a week, if not 7, and long hours during the day and into the evening, because many of our residents who are experiencing homelessness do work and can't access a hub during work hours, but may need to come in an evening time on a weekend. The other thing that's interesting about Horizon House is that they are getting into the housing business. So they're not simply a stereotypical shelter, if you will. They are getting ready to break ground on permanent supportive housing apartments that will be located adjacent to their center, and are thinking about doing more than permanent supportive housing. So getting into temporary beds, if not low barrier beds like we've been discussing. So the idea would be to perhaps use Horizon House as our hypothetical case if we're going to present a scenario or group of scenarios to the governor and to the legislature. Let's include what is essentially the expansion and scale up of Horizon House's work as one of those options. From a practicality standpoint, it doesn't seem like it makes good sense to spend finite public resources building something that we would just duplicate Horizon House to begin with. And I think we have the potential, given Horizon House's track record locally, to attract philanthropy if we're looking at a scenario that includes the scale of Horizon House. So we asked the leadership team there if they would be willing to kind of help us with a hypothetical exercise. Oh, Tom, I should have brought that.
Yeah.
We can circulate this to the group. Tom has an infographic that really is the strategic plan for Horizon House, the goal of the housing hub. So they will work with us on operating cost estimates for what the navigation center or housing hub component of our work might look like, and we can think about the location. But in essence, one location could be on the existing Horizon House property, which is near the corner of Southeastern Avenue and East Washington Street downtown. There is potentially land available adjacent to Horizon House that could facilitate an expansion.
It seems to be an adequate amount of land that
Seems like it,
that we could create these additional service to do the wraparound.
but we thought it was important to get real life operating cost estimates, and that's what they really have. They know how much they're spending in their 2022 budget, and they're working on what that expanded model might cost on top of that normal.
So whatever facility gets developed, I think we're clear that it's got to be one stop. And that's really what we don't have right now. And when we took our trip to Lafayette with IMPD and the city and everybody else downtown Indy, it's very clear that that is the facility that we need in the city, that it takes care of the day room every day. I mean, it's every day. It's 7 days a week. It's got the medical services there. It's got everything. So just to kind of give you.
And Horizon House does have, I mean, the Pedigo clinic that Lauren was talking about, which
It's
is
a
a
nice clinic.
federally qualified health center, is located in Horizon House.
Yeah, I was very impressed with their clinic for sure.
Yeah.
So basically what you do is you have the unsheltered, you have the sheltered. And we got to draw upon those. We have to draw upon the interim house people and then the permanent. Because one of the things that I've learned, and there's people on this call who have known this much sooner than I, but once you get people in permanent supportive housing, they gotta eat. They gotta find a job. They gotta get a license. So I've told the story many times, the person that I know, he's back, he's housed, but he's on the circle every day because he's got to eat and he's got to care for himself. So it is critical. This isn't just about the homeless person that comes in for the first time. This is for the entire system that we move into this hub to address these issues. Because I do think that's critical to the process, that we are taking care of a vast amount of people. And some of the things that we talked about at the meeting that is consistent with Lafayette as well as there's outreach. And I think with what Lauren talked about, it's face to face on the street. I mean, they're out there and they need people coming up to them, and there's some of that going on, but there needs to be more of it. So you got the outreach, the basic needs. When people move into housing, they gotta have bowls, forks. People don't think about that, but that's gonna be critical from an ongoing funding, case management, CES assessment, peer support, medical, workforce development. Once they're in there, you gotta get them a job, because otherwise they're gonna be back out there. Document special, legal, if they got legal issues, where do I go to address my legal issues? Food stamps, the SNAP app, BMV, all these things, PAD mission, are all in one location. And health is a critical component. That once you get someone in clearly with a health problem, that I think we all know, I'm not gonna throw out a percentage because I've heard so many different percentages, but many people that are homeless are battling mental illness or substance abuse. It's a very high percentage. We'll leave it at that. That if we can get them in the system and get them cared for and not have gaps, like we talked about there, that this medical system can get them in. And I know we talk about Eskenazi a lot, but I'm personally fairly confident that we can talk to IU Health and even Ascension to be part of this process and this conversation to work at this hub facility. So we want to talk to all three. So that was the big thing from our meeting that we talked about, is we have to centralize, we have to have a location, because what Lauren talked about is a prime example of the gap. No fault of hers, no fault of the system, but I think we can solve that issue with what we're talking about. So that was a very important meeting, and obviously Chelsea and Jeff have been deep in this for a long time, but the Lafayette scenario works. I mean, we were there, and it works, and it takes you from temporary housing interim, where you could get a bed for 13, 14 days, get a little dresser and a bed on the interim side in this facility, and then the caseworkers can really start working to help you get into permanent. So it solves so many problems. But what Jeff and I talked about, and then I'll have you talk about that meeting that we had this morning, is all this, the operating costs are significant, but we gotta get more people on the street. We gotta get more money flowing to this issue, so.
Yeah, and the appeal of Horizon House, so this could look a little bit different than Lafayette in that what we may have is a campus of buildings that maybe aren't attached, but are close enough across the parking lot or in proximity that it.
Preferred can be attached.
Yeah, that it can act as a campus.
Yes.
And having housing at sort of all levels from, you know, low barrier sort of emergency crisis housing, up through permanent housing, within, you know, eyesight of the housing hub that could be across the parking lot. So at the same time, well, so the mayor, earlier in August, convened a group that we're sort of calling the Supportive Housing Task Force to talk about the permanent end of the housing continuum. How do we get people housed who are experiencing homelessness permanently and support them with services to keep them housed? Because there always has to be a development pipeline of units to fulfill what will be an ongoing need.
Jake knows about that.
Yeah, that's right. And Jake's on the list. So the person who's really helping us lead that supportive housing pipeline work is Mike Petrie, who is the president of Merchants Bank, and has a subsidiary nonprofit called Merchants Affordable Housing. Merchants Affordable Housing has been a partner with the city on so much of our work during the COVID response. So Mike is interested in helping us on the development side. So it's one thing to know how much Horizon House costs to operate its day shelter and the wraparound, the housing hub and navigation services. It's another thing to build units, whether they're low barrier or permanent. We need to know what is a construction cost, and we need to know what it costs annually to operate those housing units. And so that's where,
Along with the hub as well.
along with the hub, yeah, these things function in concert with one another. So Tom and I went up and met with Mike this morning, and Mike is very interested in continuing to develop permanent housing, but there is a distinct possibility, I think a really good possibility, that if we're developing low barrier units, that they can be connected to or on site with those permanent.
So they could utilize those services, right?
That's right. Yeah, that's right. And so Mike is going to help us think about cost for construction, cost for operation of what we might build through this effort that includes low barrier units. And then, as Tom and I have discussed, when we make recommendations to the governor, to the General Assembly, it makes sense to make recommendations across the system, not just for this one building. So there is an ongoing need right now today regarding funding for those ongoing support services. We don't have enough, and we don't have a sustainable source of funds. We have a philanthropic source that's going to help us for several years, but is not contemplated to be a permanent source of funding. And so a budget for support services for our permanently housed residents who were formerly homeless is going to be posted.
Let's open up for some discussion now, just about this concept. As we move into September, we'd like to really start laying out what those funding needs would be, category by category. For example, Mike Petrie when we met this morning, and there's a lot of numbers flying around, but I think we have a good sense of what a homeless person costs city, the county on an annual basis, and it's much more expensive than what we're talking about on a per head basis. And so we know that, but then Mike talked about the fact that, and Chelsea, you can jump in if you agree or disagree, that it would take one caseworker to deal with 15 or 20 units of permanent, because they need help. Just because you get them housed, man, that's part of the answer, not the whole answer. So there clearly needs to be more outreach, more people on the streets, more people supporting the permanent housing to allow them to not stay on the street asking for money through workforce development. So this machine clearly needs to be fed.
Pre-COVID, it was not uncommon for our service providers locally to have caseloads that were 1 to 50, 1 to 75, and just completely not tenable for providing the type of intensive ongoing services that our residents need. What we found with the benefit of CARES Act funds and the support of CICF and what we call the Housing to Recovery Fund is when you can get caseloads down to 1 to 20 or 1 to 15, you can really keep people housed. And Horizon House has shown that in the pilot project that we've run with them. They have somewhere around a 97% retention rate. Once a person's been housed, they have stayed housed for 2 years. So the numbers are beginning to bear it out. Where the challenge is that sustainable source of funding, and then, as Lauren alluded to, finding the people to actually do the work.
Let's open it up for some discussion.
Jeff, where are we at with the FSSA waiver? You know, what have you heard in terms of FSSA? We were having conversations with FSA about their waiver and trying to reimbursement for wraparound services. That would be a source of federal funds to help offset costs.
So Chelsea, I may ask you to chime in here if you know, or you can text me if you don't know the answer. So my understanding from Rodney Stockman, who works in our office as the policy director for homelessness for the mayor, is that it is a multi-year process to get that waiver in place, and that FSSA had begun that process, but we're probably looking at 2 to 3 years before it's.
Do we know how much money that could be in terms of helping fill gaps? And
Do we know? Do we have a sense of the financial impact of what the Medicaid waiver might bring?
We did have that crosswalk study done. That crosswalk study has the actual dollar savings amount.
Yeah, I don't know if I've seen it.
Do you mind checking that, and if you do find it, we could get it out to the group.
right, because even if we had to ask for a gap fill from the state and, you know, from somewhere, from city state, until that gets approved, you know, but
Yeah.
to know that funding will be coming is part of
Yeah.
the overall picture.
Chelsea?
Yeah, I was gonna say the latest we heard, we just, Lori Phillips Steele is with Indiana's Corporation for Supportive Housing team, and her group helped lead that crosswalk that Jake just referenced. And Lori seemed to indicate it was like a 3 to 4 year process. And the waiver is really an administrative change. It doesn't require a legislative change, but it does have budget implications that would have to go through the state legislature. So then the timing of all that would have to align with then a budget year. So Jake, I know, Lori may be able to speak more to what the budget implications are, but there would be some fiscal implications, even though our understanding is it's an administrative change. But it's several years.
Go ahead, Jeff.
Well, I know that there are some other groups that are working on the mental health related issue in relation to FSA getting a waiver. And, I think I talked very briefly about the Tucson.
Yes, you
happened
did.
in Arizona, and they have a waiver out there. Texas has a waiver. What they've done, to Justin's point, is they've also added a small strip of state funding to add to that. But we're talking about something that would work on a statewide level, but it wouldn't exclude what you're talking about here at all.
I see. Okay, that's helpful.
The rationale behind the Housing to Recovery Fund was that it would be temporary to be the bridge to the Medicaid waiver. We're probably gonna miss, but I don't know, maybe not. I mean, we're kind of only a year, 2 years into the Housing to Recovery Fund really being implemented. So there may be funds there that get us to Medicaid waiver. We have a housing trust fund, which is local dollars, and we work with IHCDA to unlock even more local dollars, and we've committed.
Is that the 10%?
So this is the money that's generated by recording fees. in
Yeah,
America.
the recording. fee.
And we generate between $1 million and $1.5 million per year in purely local revenue. And we dedicated $2 million of housing trust funds to service this funding this year. We'll keep doing that for as long as we have that amount of funds available.
Well, aren't some of the funds for the dedicated housing that Horizon's talking about that come out of tax credits from the Indiana Housing Authority?
Is Compass, I think Compass is a tax credit deal. Yeah, I think it's a 9%. Yeah.
Yeah.
And so many of our, so there are a couple of ways that permanent housing gets developed, permanent affordable housing and supportive housing. The biggest way and maybe easiest way is using those housing tax credits that IHCDA administers. It's a competitive process. It's statewide, and so we're always up against other applications from across the state. But IHCD has been very generous in supporting projects, especially supporting housing projects that have come through.
Yeah, through the Institute, we selected, that allows us to create a pipeline of development for permanent supportive housing across the entire state. Since 2017, just here in Marion County, we have financed 9 developments for permanent supportive housing. 3 of those are in operation right now. 2 of them are under construction, and then we have 4 that are just waiting to close on their financing. And so those are the numbers from 2017 to just this month.
It is,
Yeah, we have another 400 plus units, supportive housing units specifically in development.
And some of these units, some of these developments target different types of population. Some are transitioning out of youth foster care. We have one development on the near west side that's focused on our veterans. So they do, some of them may target specific populations, while they all are should be part of the coordinated entry, the COC, the care, where I think we talked about identifying the highest need individual or household based on certain information, so that they would be the ones that would be selected to live at these properties.
I saw one thing that was interesting. We had IHCDA board meeting. And I told Jake I wasn't surprised about the fact that actually the numbers are down a little bit, because you got rising costs of 20% higher. You've got all these macro effects, which I deal with and other people in the industry. So not surprising, we're seeing a little bit of a dip. So if there is maybe something that could be done to help stimulate that, not just in Marion County, but throughout the state, I think that's worth looking at. And I don't know exactly what that would be, but I think it would be worth a discussion statewide.
We talked about shortage of personnel and staffing.
Yes.
I know Tim and I had talked about, do you have any additional information from what we talked about before?
Yeah, I sent an email out to Chancellor Klein at IUPUI, just to kind of thinking outside the box about, educational pipeline, because you're gonna need professionals to administer these services, those wraparound services. So we're talking about, master's level, social work.
Yeah.
We're talking about those that are in their residency, psychology residencies and things like that. Just to build that pipeline, so you're always thinking about, that next generation coming in. They can work as graduate students getting into their actual masters, getting into their doctoral residency programs, their qualifications and things like that, almost like a practicum. but you have those professional services being administered. And then obviously, when they get in their profession, you probably can't afford them, but, it's just something.
But in the interim.
Right, in
probably
the interim,
could.
you have those services being provided, so.
That's awesome.
You're
I'm
still
glad
waiting
you
for
did.
it to get that.
So an MSW pipeline would be huge. And, Tom and I talked about this earlier today, like, at the city, we've talked about, like, do we get into the business of employing those caseworkers ourselves? Right now, they're employed by, nonprofit organizations that are our service providers. But they're, I think, rightfully concerned about financial sustainability, and are these positions permanent, and how are they being funded? And, so they're leery to maybe go out and hire 5 new caseworkers if they don't know they're gonna still have sustainable funding a year or 2 years from now. Well, does the city need to think about that? And maybe it's through the Office of Public Health and Safety or something like that, where we just
We gotta have people on the ground.
we just begin to employ case managers.
Well, and to add to that, Tim and Jeff, we've been talking about talent pipeline for a while, and COVID definitely exacerbated the need, to bring more people into this work. But another way outside of, or in addition to kind of a master's of social work pathway, are peer support specialists. So
Yes.
peer
Yeah, that's right.
supports are people with lived experience, and oftentimes lived experience plus substance use. They're in recovery, or they have a mental health condition, or they've been justice involved. So there are, peer recovery coaches and forensic peers. There's kind of a whole pipeline of peer supports that are critical to this work and have really shown great outcomes, particularly when they work in supportive housing projects, because you have somebody who has been there, who has walked in the shoes of the folks that are being served, that oftentimes reflects demographically the people being served. And that matters. And so we've done a couple cohorts of peer supports with the Corporation for Supportive Housing to get them trained and certified. And it is a certified title, right? So there's state certifications that people have to go through to get peer specialist certification, recovery certification. And Jeff, I think I heard Rodney mention that there may be $3.4 million coming to expand peer support training and certification and bring more peers into this work. And that's another pipeline opportunity, I think.
Where's that 3.4 million coming from?
I think it's coming through the Department of Metropolitan Development. I don't exactly know the source. Rodney just talked about it last week on one of the community calls to really expand that pipeline.
Yeah. Don't let it go away. Okay. Any other comments, thoughts on the topics?
I'll just be brief. I think the coordination within the social service sector is super critical. It's a very hard nut to crack. I've seen so much genuine, compassionate work among nonprofits that sometimes does not lead to results. So for example, on the housing issue, I've worked with nonprofits that referred individuals to other nonprofits, and those initial nonprofits checked the box and reported a 90% placement rate at a time when they were moving people to another nonprofit to handle. I look at the existing infrastructure, what can be leveraged to be, like the 211 services, for example, or the AAA agencies for nursing for older citizens. That is the missing strategic piece, to have something at the front end of this initiative that can be a warm handshake and actual connection to services. Otherwise, I think the vision of this initiative will be more focused on the facility, the staffing. People go through and they're going to cycle through the system, but once they go back, it's the same exact issue. So I hope that as we move forward through any funding mechanism, that we play a strategic role in being sure that maybe we can come up with a model that can be unique and effective, that can be replicated and scaled, as far as how can you connect social services to truly work for someone to map that process and say, from point A to point Z, when someone walks through the center, here's how everything's gonna work.
Yeah.
So that's the difference.
It's like running a company, no matter what happens, you have a SOP that runs you through everything, which that's a great point, that we should be able to solve for every scenario where you go from a standing operating procedure at that why, what do you do? So everyone knows it, and that's across the board. So it's a great point.
I'd like to, I'm sorry, I'd like to back up with Representative Codora said, is that statistically, I mean, how many beds are you looking at? How many beds are you going to need? And how many people do you actually think are going to recover? Because statistically, the numbers aren't good. To leverage current resources to open the facility on night shift, you would want to use paramedics to be able to manage people who were in a schizophrenic state, to be able to manage alcoholics, to be able to maybe quite possibly, give somebody an injection of medication that'll keep them sane for 3 months. Those types of things. How are we going to actually treat the people, and what are the number of houses do you think you're going to need, and how many do you think you're actually going to get to be able to recover?
Excellent. Well, just thanks to be about that.
In a previous meeting, John Licklider, former chairman and CEO of Lilly, spoke to our group about that very topic. And, a lot of times, it can take 2 years, that you have to keep them in the system for 2 years under care to really get that permanent solution. So no doubt that it's critical that once they get out to permanent supportive housing, we need the people to care for them. And that gets back to this ratio. But you're absolutely right. You can't put them out there without taking care of them, or we'll fail. Any other discussion? So the next item on the agenda is to really talk about the September meeting. And at the September meeting, we've talked about it, broad concepts, but in September, I think we really need to start laying out what these funding needs are. What's the permanent housing issue? How do we deal with the hub concept? What are some of the operating expenses? It's not something that could be done in November, so we have to start in September. So we would obviously like everyone's input as we start working on that, particularly those at the state would be very helpful. But I think we have to start to box this a little bit as an initial draft discussion of some of the needs and some of the sources. Jeff, you want to jump in?
So I think we begin to, and we can kind of take a stab at this just in the weeks we have between this meeting and the next meeting, maybe coming up with kind of at least a topic or subject-based outline for what a report might look like. And it's more than simply building, X number of beds kind of in a vacuum. There really is more about the continuum of housing from that emergency entry point that might fill a gap in the existing system of shelter to permanent housing. In a perfect world, we are developing enough permanent housing units on an annual basis that we don't need a shelter. But we're not there, even with 400 plus units in the pipeline, that's not enough. And so as we scale up the production or acquisition of permanent housing to serve residents, there will still be a need for the emergency component. The AIC doesn't fill that gap. Wheeler and other faith-based shelters are filling as much of the gap as they possibly can, but there's still a delta. And we need to think about that piece, but then how does that piece lead to or access the permanent housing? And so that's, I guess I'll give myself a homework assignment to sort of map this out and share it with the group. Where I think
the only thing I would say, and this is for a discussion, but even if you have knows how many years that we're able to really start to catch up, knowing that these projects take time to build, I would believe that the hub would always be necessary because that person that got off the Greyhound is always going to need a place as a day room, is always going to need a place to come into the system on a temporary, then an interim, then a permanent. So I think this solves short-term and long.
I think we're always going to have residents who are facing a crisis. And, despite of what I think we would all like to do, unfortunately, homelessness will always exist in our community. But it's how you intervene to keep that episode as short as possible and to mitigate the damage that can be done from chronic homelessness.
Have we had the conversation about reentry and folks that are getting released and how we coordinate with them getting connected to the hub or to housing? Because I know in Marion County, there's an abnormally high number of releases that do happen here as opposed to other places. So how do we make sure that that's?
Is that still happening at Wheeler? I mean, whether, at least anecdotally, still happening at Wheeler?
So I know as DOC, we do utilize Wheeler, at times as a last resort, of course, but yeah.
We had a conversation we had a conversation at our last meeting that, the prosecutor's office, we all discussed it, would love to have a location that a judge could then have the authority to send them to that location. Because right now, the judge, based upon what the prosecutor is saying, the judge doesn't really have the ability because of the lack of beds in the Marion County Jail. So instead of putting them in jail, it's just, they're out.
So this is slightly different. This is, these are people who have completed their time.
Right.
And are
Right.
being returned from the Department of Corrections to Indianapolis.
Yeah, I just took it a step
Yeah.
further, that you also then have
Yeah,
Yeah,
those
jail.
that should go
Yeah.
into a hub.
Yeah, that's right.
That there's not a system to put them in the hub.
yeah.
But I-
Because the judges don't have a location where they can say, you have to do 2 weeks at this location.
I know we've had, some conversations with Wheeler over the years about DOC releases, and it kind of becomes an unfunded mandate either for Wheeler or for the city, so getting a handle. on that.
It still happens a little bit. I don't think it's happening as much as what it used to be, where, we'd get a lot of people, but, it's happening some. But that's the thing, work in some ways, Wheeler's acting as that hub right now, because somebody gets off the bus or gets into town, where's the first thing they go? The people point them to Wheeler Mission. So in some ways, we're already operating as that hub, and glad to do it. Because we're trying to get people off the street as well.
Yeah, I totally agree, Rick. But back to that point that was mentioned by the prosecutor, there's something to be said about that inside this final
Well,
study.
I mean, that's supposed to be the point of the AIC,
Yeah,
but right now, admission to the AIC is voluntary, so it's the involuntary piece that I don't, I think that's missing.
Well, with 60 beds, I mean, the AIC wouldn't
Yeah.
be big enough anyway.
It's kind
I'm just assuming that you're right.
Right, but I don't know that we're gonna build a facility that's infinitely sized to take in everyone that, I mean, we're not Central State, that's a state hospital.
It's interesting. We work with the courts in Bloomington, with our addiction recovery center down there, and some of the guys that come out of prison or in front of the judge, put it that way, the judge gives them the option if they want to stay in jail, or they can come to Wheeler in the addiction program. And you wouldn't believe some of them choose to stay in jail, and they don't want to come to an addiction center and work on their problem. They'd rather stay in jail. So that's kind of the mindset you have there too with some of the folks that we work with.
okay, thank you, Rick. So any other points? Last time we went a little longer. It's been about close to an hour 15, so I want to be respectful of everyone's time. But I do think that the next meeting is very critical as we start digging into these levels and points.
I just want to make sure that I captured what Jeff was saying. With that footprint, are you actually saying you're gonna have either state agencies providing service or city agencies providing services within that footprint? Is that footprint big enough for that, or are you thinking something else?
I will speak as the non-city, but more of a neutral party on this point. I think the answer is yes to your question, that this be a hub that services all the components of the central business district and the surrounding downtown area. Because I just think it's beyond what, excuse me, it's beyond what I think the city can fund, my opinion. But I think it needs to be a joint effort for sure.
And Tim, it would provide space, at least, the way we're talking about it, it'd be, co-locating services both from partner agencies, service providers. So you may have, a homeless initiative program having space at Horizon House to provide housing navigation support. You may have the BMV as a state agency coming in to help with acquiring driver's licenses and things. So it'd be a way to co-locate both services from other agencies that would have space in the hub and come in, as well as city and state agencies that could come in, 2 or 3 times a week to provide documentation services, expungement services, those kinds of things, so that everything is centralized in one location. And, Horizon House has started to socialize this with some partner agencies. Last week presented it to HIP and Adult and Child and, several agencies to say, would you be open to sending staff here a couple days a week, if we had something like this? And there was a lot of excitement around that, of having a centralized core location where services can all be together.
So that's why I answered the question is yes, in my opinion.
Well, they actually did that in San Antonio and Haven for Hope, where they actually opened up services to that area where they were located, not only to those individuals that were in the actual programs, but even to the community. And it was a selling point because now the community that, it was kind of abandoned from getting those actual services, they can actually walk in and get services because they had it front facing. So if I needed to, have, see an optometrist, or if I needed to, take my kids into, for dental work, there's somebody on site, but it's still close enough to the community where I can walk back home or whatever.
I didn't know that.
And it was a great selling point.
We used to have an event in Indianapolis called the Homeless Connect, and it was a one-day, one-stop shop at the convention center. And I mean, this is the model for that, just over the course of 7 days a week.
That's interesting. Okay. If there's not any other questions or comments. Yes, sir.
So the next meeting is on September 29th, correct? I'm looking at the calendar. I think it's on Thursday. And I was appointed to the Housing Task Force, which is separate than this, or different from this group. And we're scheduled to meet at the same exact time from 10 to 12 at room 404.
That's how it always happens, right?
So I just want to give you a heads up. I'm not sure if anybody else, Senator Stanley, are you on that committee too?
Nope, I'm scheduled here.
Okay. So I guess I'll miss
Jake probably is.
Yes, I'm on that. It is task force.
So maybe I can, if there's anything that I can contribute in terms of feedback, I'll be more than happy to connect with both of you before the committee.
Shoot. Okay. Cool.
Am I right? It's at 10 a.m. on?
Yeah.
Okay.
I'm sure somebody didn't have.
All right. With discussion complete, I will call the meeting adjourned. Thank you for everyone's participation. Hopefully we have a very productive September meeting. And if anyone on the committee would like to share things with Jeff and myself prior to that, we are all ears, because I think that's going to be the first step.
Yeah, I would hopefully maybe the week after Labor Day weeks and 2 weeks from now, we can circulate kind of a skeletal.
Yeah, that would be awesome. That'd be awesome. Thanks, everybody.
Thanks, everyone.
Thank you, everybody.